you very much.
All right, good morning. This is Friday, April 12th. Thank goodness for Friday. And it's always nice to see a weekend coming up.
And no snow.
And it is Senate Health and Welfare. So good morning, everyone. This morning, we're looking at H 721 and some budget discussion a little bit later. And we have with us Stephanie Barrett and Danny Fulco. Is that how I said it?
Yeah,
You don't know everyone on the committee, so we're gonna introduce ourselves.
thank you.
Oh, hi, I'm Martina Malafi, I live in Burlington and represent Chittenden Central. Nice to meet you.
Good morning, Dave Lee, Sullivan Proctor, I represent Rutland County.
Jenny Lyons, Chittenden Southeast,
Terry Williams, Sullivan Pulteney, and I represent Rutland County.
and Ruth Hardy will be in a bit. She's looking for herself.
No,
Not
yeah.
fun.
Shoot.
Oh, not fun. So, thank you for being here. Obviously, we're looking at 721, and we've asked Diva in to help us out with what it might look like at different levels. We're particularly interested in the Medicare Savings Program, but also the other sections of the bill, so we'll let you.
So we'll start with Medicare savings, because that's
That's good.
the document you have in front of you.
Okay,
I'm Stephanie Barrett, CFO at DIPA. And Danny will go over a little bit of an overview of the Medicare savings programs for the committee, and we'll talk a little bit about the farm, and then we'll go into the couple slides that are, the current status quo, fiscally of the buy-in and Medicare savings programs, and then the cost estimates on a slate of options for expansion.
thank you. That's helpful.
Okay.
Do you want to share screen or not? We've got this, so we're set.
You have it?
Kiki, if you could send me the Zoom link, I'd be happy to share my screen.
Okay, let's do that, because there are people who are out in the Zoom world who are keeping an eye on what we're doing.
And I imagine this is up on your committee page. of the
Yes,
document too.
got it. We have what you gave us. Good. Okay. For the record.
So for the record, I'm Danny Fiacco. I'm a senior policy and implementation analyst with the Department of Vermont Health Access. And I'm going to do an overview of the Medicare savings programs. So we have 3 Medicare savings programs that we're going to talk about today. There's the qualified Medicare beneficiaries, which we refer to as QIMBY. We specified low-income Medicare beneficiaries, which we have shortened to SLIMB, and we have qualified individuals or the QI program. And so these are Medicare savings programs, but they are all managed by state Medicaid agencies. There are mandatory eligibility groups for Medicaid, and so Medicaid state agencies are in charge of administering them. And all of these programs are paying your Medicare Part B as an employee premium. This is your medical insurance. And then the QIMBY program will also cover if you are subject to a premium for Part A. Many people are not, but if you are, you can have your Part A premium covered as well as all of your Medicare Part A and B cost sharing and deductible. So it is a full wrap of your A and B benefit for folks who are on Medicare. Anyone who's found eligible for a Medicare savings program is also deemed eligible for a program called Extra Help or the Low Income Subsidy. This program is administered by the Social Security Administration, and it is wrapping your Medicare drug coverage. So you have a federal program that'll help you wrap your drug coverage and lower your out-of-pocket costs for drugs if you're found eligible for any one of these programs. So currently, the income limit for QIMBY in the state of Vermont is 100% of the poverty level. There's no asset test for any of these programs. Vermont waived the asset test for all of these programs back in 2005.
That's right.
SLIMB is between 100 and 120% of the poverty level. And then QI goes from about 121 to 135% of the poverty level. And this is the federal income limit for these programs. that is, set at a federal level, but states have options. One of the options is that they can disregard income or resources, for these programs, which we have done for resources for them.
That's only at the QI level? No, it's at all level.
We have, all of the
Yeah.
programs have the asset test to support it. And then, what we're looking at in this bill is, expansion of the three programs.
And so just, any expansion of the MSP programs couldn't be couldn't be effective until January 1st, 2026. Guidance is, so when we're talking about the fiscal impact, there's not a programmatic impact in FY 25, but that programmatic impact would start in state fiscal year 26. And it does come with implementation costs, if we have to, these are a program that's for eligibility, programmed in the access system, our oldest system.
It's a lovely video thing.
But that implementation cost, would have to be appropriated in state fiscal year 25. And this might be a good time to, before we go into the next slide, talk about the V-Farm program for a little bit, because as you can see on this slide, we have dual eligibles that we buy into Medicare. So those are folks that are full Medicaid, full Medicare. You have the MSP programs, and then we have the state V-Farm program.
Right, so the state V-Farm program, it's authorized both through, we've got state statute on V-Farm, and there's also 1115 Medicaid waiver that authorizes V-Farm. V-Farm is as old as Part D drug coverage for Medicare itself. So it's been around since 2006, and it essentially is a program that's wrapping your Medicare drug coverage. If you are eligible for that program I mentioned earlier, Extra Health through Social Security, it is paying after this Extra Health program. So it's taking a little bit of money off your co-pays. If you have, for the Extra Health program, your co-pays are somewhere between $1 and maybe $5 right now. I didn't quote me on that. V-Farm co-pays are only $1 or $2 for your drugs. And it also offers more extensive coverage than your Part D plan. So everyone on V-Farm right now has the same prescription drug coverage as folks on full Medicaid. And so V-Farm is for folks who are over the income limit for full Medicaid. There's 3 tiers of V-Farm. V-Farm 1 goes up to 150% of the poverty level. There's a $15 premium that people pay to get on V-Farm 1. V-Farm 1 also offers a little extra in terms of benefits. There's an eye exam. V-Farm 2 is 150 to 175% of the poverty level. Premium there, I believe, is $20 a month. And it's again the full prescription drug coverage that the Medicaid program offers. V-Farm 3 is 175% of the poverty level, up to 225% of the poverty level. And that monthly premium is $50. And again, that's a full Medicaid kind of drug benefit behind it. And so what that means is for folks who are over the income limit for the Medicare savings programs and over the income limit for the federal Extra Health program, they're getting their Part D or Medicare drug coverage, deductibles and co-pays and premiums paid for. So in paying their V-Farm premiums to the state is then providing that extra help.
What was the amount that the individual's responsible for at level 3?
$50.
$50.
They just said V-Farm also covers drugs at Part D.
Yes.
There's a,
Yeah, so when I say it's like the full Medicaid, sorry, thank you for the full Medicaid benefit. There are some excluded drug classes from Medicare that Medicaid does cover. And I think that's the one that most people think of is over the counter. So if you have a medically necessary prescription for an over the counter drug, that may be covered under V-Farm and would not be covered under Part D.
For the nutritional supplement type.
Right.
Yeah.
Yeah.
This is really helpful. I was wondering, I know you've already put together the slides, but if you could add a slide on bee farm that just basically
Laid out.
laid out what you just said.
We probably have it even on our
You
website.
probably do.
Yeah.
Because that would be
As
helpful.
this slide.
Yeah.
So what you see on this slide is our current enrollment, probably a couple months older analysis when we started this, but the duals, that's around 22,000, just under 22,400 duals in our population. And nothing about this changes that, it's just that they're part of the buy-in. The way the buy-in works is we get the invoices from the federal government, so we start with a picture of everything. And then the three Medicare savings plans, Quimby, Slimby, and QI. Those are a little bit under 8,000 individuals in total. And then Bee Farm, the thing to know about Bee Farm is that there are folks that are both on Bee Farm and one of the MSP programs. And so if anyone pays close attention to the emergency board, the Bee Farm caseload is 9,200 that you've adopted. What I'm showing here is the 4,000 that remain only on Bee Farm, and the ones that are already in an MFP are up in the MFP counts. That's matters to how we build the model for costing. And then what we are budgeted for in FY 25, just under $47 million for the dual buy-in. $20 million for the combination of Slimby, Quimby, and qualified individuals. The match for those is $5.9 million, and the qualified individuals are fully federally funded. The Quimby and Slimby are Medicaid matched, and so that's the reason that differential is not that normal sort of 42-58 split. It's a much more advantageous to the state with the Q1s, the QIs that are 100% federally funded. And then the Bee Farm programs, all 1, 2, and 3 together, are $6 million gross, $4.8 million general fund. And so we are actually able to match that slice of Bee Farm that pays for the non-Medicare covered drugs under Medicaid matched. We have to pay for the part of Bee Farm that is the supplement to Medicare entirely with general fund dollars. We can't match that. And the $6 million is net of the premiums that folks pay to come on to Bee Farm. So I'm gonna stop there for a moment. And that's the status quo picture.
Okay, that's where we are now.
That's what's in place right now. And then the next slide are expansion options. And these are a little bit different than the expansion options that were presented. We presented a slate to the House based on the House Committee's task of various slices and pieces. And when we started that, we had a question that we went to the federal government with about the qualified individuals, the pot that the group that is 100% federally funded, because there's an allocation cap at the federal level, and we were unclear when and how that would hit at a statewide basis or a national basis. And so there was a bit of back and forth there on the House side. What we're showing here are A, B, and C options. A is very similar to what was option 2 in the House. Option C is very similar to what was option 3 in the House. Senator Kitchell asked us to run what was in the middle. The alternate option is the option that's sort of maximizing federal dollars that's tops out at the same level as the option that the House chose. And I think I'm just gonna go out on a limb. The House has been able to take a little bit more time and process the what we got back from the federal government as an answer. They might have altered their option 1 approach a little bit. And so I'm just gonna walk through the sheet.
Please.
So in option A, this would move the Quimby eligibility up from where it is now at 100%. to 150%. We would not do a SLIMBY option in the state. And then we would move to 200% for the qualified individuals. And that's the highest we could move.
So,
And still get federally funded.
Well,
Right.
with they're locked together.
Okay.
In a sense, so.
essentially, CMS will approve an expansion to SLIMB or QI, but you cannot expand them more than you've expanded your QIMBY program. So if you're expanding QIMBY by 50% of the FPL,
You can't expand the other one, but.
correct, you could do QI up to 50% of the FPLs.
And so, in that, because it goes up, the QI goes up to 200%, that's still below the 225, that is the top level of V Farm. You will have a remaining sort of V Farm free, piece that's about 50% of the V Farm free piece. And then, and we have to have a longer conversation about V Farm and transition as well, if you do go forward with an expansion. But what that set of options of eligibility would end up with, from our perspective, of the 34,000 folks that are on right now, 10,000, just under 11,000 folks would come on under this, onto the program,
Right there. Right.
under this scenario in our estimate. The net total new cost to the program is $30.7 million. The general fund share of that is $6 million. That's because a lot of the new, almost 11,000 people coming on are qualified individuals, fully covered by federal dollars. And then this is just stepping down in 5% increments of the QIMBY. So option B, is 145% of poverty for the eligibility for the QIMBY program. That means that the qualified individuals can go to 190. Leaves you about 70% of the people in the V Farm free category. The net new enrollments are now just under 9,000 folks, $25 million of new costs, and just under $4.7 million as a state general fund cost to the program. And then option C is stepping QIMBY down. It's still an increase from 100 to 140% of poverty. Then you could do the qualified individuals to 180%. You have about that 10% rate. That's supposed to be 90%. Typed in the wrong number there, I'm sorry. You have about 90% of the V Farm freeze left in V Farm 3. I just picked up the wrong side of the equation. Sorry about that. You have about 4,400 new folks to the program. $13 million of new total gross cost, but it only has a $1.7 million state general fund cost. And I'll just share that
Take your question, write that question down. Because there's the next step is questions.
the tax department does a great job of over 65 data by AGI cohorts. So we had a pretty good data set to estimate where people might fall in terms of this population. And so the reason you're seeing differences is because the way that the FPL cohorts are showing up primarily. And then still going down to the alternate scenario just below A, B, and C. So this is the scenario that would top out at 225% of poverty in the qualified individuals. That means that the QIMBY level of eligibility would be 167.5% of FPL. That one brings you just under 16,000 new folks into the program, just under $46 million total cost, and a $10 million state general fund cost. And so, just to be clear on the qualified individuals, there is potentially some year risk that there will be some general fund cost on the qualified individuals when that national allocation for qualified individuals is hit. That could mean that states start to have to pick up part of the qualified individual cost.
So QI is, the way that the QI funding works on a federal level is that the Health and Human Services is allocated a set amount of money for the entire QI program. And this is based on like CMS actuaries estimating how many Medicare beneficiaries are in the country between 120% and 135% of the federal poverty level. And then that money is a pot of money shared among states every year. And so there are estimates of how many of these folks will be in each state. Each state is done like a preliminary allotment, and then there's a process to reallocate during the year. So one state may not have spent all of their QI allotment, and other states may have gone over. And as long as all of the states are staying under that federal cap, then the money can be shuffled around and everyone can have their needs met. What was unclear when we first started discussing this bill is like, has anyone ever met that cap? And the answer seems to be no, on a federal level, no one's actually ever used up all of the QI. However, if states are disregarding income at state auction, that doesn't change how the QI allocation is calculated. It is still based on 120 to 135 across the country. So at some point, if every state were to expand their QI extensively, yes, then at some point that cap, that money would be all eaten up and states would start feeling some state costs, because once you exceed your allocation, it's 0% federal match. So if a large state like California were to greatly extend their QI program, would that eat up? You know, it's just a matter of when.
But it is, yeah, when, and so it's out there, but right now.
But it
But it feels like the states have been sort of careful about avoiding that.
But we do have some states that have expanded.
They had, but,
New York has expanded and Maine is expanding.
well. So are we at questions? Because I've got
It's already expanded.
questions and then we'll expand to others. Are you ready for questions, or you wanna talk more about the
Can we just talk about-
farm transition? Can we
Yes.
do that? Yeah.
So these estimates are assuming that bee farm cost drops to this, either 50, 70, 90% bee farm free, and that the savings accrue. However, you're gonna probably wanna think through how bee farm would transition.
Mhm.
And if you go forward with an expansion, we will come back with language, sort of saying this is how we think you should approach it, or, that type of thing, but.
And remember doing it the first time, so this will be fun.
Yeah, so, bee farm is also programmed in the access system for eligibility, and so there will be some probably additional costs, and so. The bill that passed the Senate, the House. It basically sunset bee farm a year out, but the option they chose topped out at the 225. You might choose a different option, and so. When you are clearer about that, we will be, sort of recommending. Probably interim steps and studies, and not a full sunset yet because of the nature of how these work together. And that's I just want you to, that requires more discussion and
Premature sunset.
yeah. And it does mean that these estimates are probably just a little understated, especially if you want to keep this benefit that is. It's about $4 million gross of the non-covered Medicare drugs that Bee Farm right now covers. That's about $4 million of the gross cost. And that would be covered by any of the MSPs. And so there are policy choices in there that you folks need to sit through.
Can I ask you a question about that?
Yeah.
After me. That's first.
Yeah,
So
we got
Chair,
questions, we have questions from everyone, so write your question down and we'll go through questions on this, so. So what you're saying is that the cost of bee farm with, for transition, or as in that.
So to the extent that you
Yeah.
keep the benefits of bee farm intact, you lose some of the savings that are assumed in this cost estimate, and
So
so.
savings would accrue to $4 million more or less.
So that's a gross dollar.
Yeah.
Yeah, that's a gross dollar amount for that piece of bee farm. But then you're also, if you keep the premiums the same way, that's bee farm has so many different pieces. And so that's just the message we wanted to bring back to you.
Do you have a quick question on bee farm, Senator Bogan?
well, on this table, if one of these two were chosen, you have bee farm as an NA.
So
That's,
The assumption here is that you would actually sunset bee farm.
even the extra benefits that
Yes,
aren't covered.
Yes, and that's,
And, or we could just choose not to, we can find another way to cover those benefits,
yeah, you'd have to.
theoretically.
Yeah. Is the way you do it now, the right, those are all the questions that you have
Yeah.
to sort of raise and.
Okay, and the reason that bee farm would go away on these two options is because the QI would go up high enough. That
It would equal the
make
top of that's the reason
Right.
for it.
Yeah, okay,
I get it.
okay.
Okay. Anything else on that?
Just one last point is,
Sure.
even though the FPL limits are, the same number, so 225% of the poverty level. The income, financial methodologies for Medicare savings programs are not the same income financial methodologies for bee farm. So under those different methodologies, you may end up at different FPLs. So we do have some folks who might be on Quimby and
At a certain
bee farm
FPL.
is free. It's so, just so that's clear, is that those aren't really apple to apple.
So bee farm's a little bit of a hitch in that.
Just so it's clear that it's not clear.
Oh, good, this is really exciting. Nothing like complexity. We never have complexity in here, so this is great. Okay, all right, I do have a couple questions, and it really, for us, it'll be looking at what number works and how many people we're helping here. But one of the things that you talked about were some of the calculations that you learned about through, the Department of Taxes and the population.
That's the basis of
Yeah, the
how we
basis of
understand,
that.
that's the basis of the model.
But,
I just wanted to share that.
The big question for me is, this is gonna become base funding,
That's,
overall.
it would be.
And so it'll be ongoing. And then the question is, what are our population trends in each of these areas? And so just Medicare overall.
So
then
it's
do
a
we have-
population trend by income, and
Do
so,
we have a look at that? Is there a way to see
so
what projections we have?
we have not projected, but the question is, this is primarily the over 65 population, but it does also include disabled folks. And the question is, if, the trend in that over 65 population and their income levels. If your lower income's growing higher than your higher income, we have not done anything beyond the first look of, based on the most current data.
Yeah, so I mean, for me, the trends have been increased population, lower income over time. We've seen that. So I'm wondering if that's a projected anything, because it will help. It will ultimately help in decision making on how much we can invest. Yeah, okay. Do you have any of that data or?
We have not tried to project it.
Yeah, no, Diva hasn't.
JFO might,
Maybe we can look,
population pieces might want to, on over 65, what the cohorts might look like by income. But there's not, most of the census data lumps together, folks, especially above the 80 age, and it's really hard to get income cohorts because Vermont is so small.
Right,
by
and then the
age
same,
categories.
what we're also talking about here is social security income, which whenever social security goes up, Medicare also goes up and takes a chunk out of it, so we are reducing income.
Well, that's another little
I
hitch to
know,
buy-in.
well,
Because that is true for individuals that are paying for their own Medicare for the
Yeah.
buy-in. The amount that Medicare goes up, I think you're limited by that same percentage increase on the Medicare. But the state actually picks up a higher cost can end up picking up a higher cost on the buy-in because of the way Medicare financing works.
Okay. So Senator Williams had a question a long time ago. You sure? All right. Questions committee, so it's the whole thing here that we have questions about. So your presentation was really clear.
Yeah, thank you.
Great. So
The,
looking at what the House passed is the highest level. And on the little table that you.
They had a higher level of committee,
and they had Slimby because you hadn't yet gotten the answers from the feds on how that would work, is that?
and they did, we had given them the answer on the Fed piece, just that the Slimby piece, how you would analyze the Slimby piece, you're gonna go up on, if you were going to accept that the risk is out there, but for now, in the near term, the qualified individuals are not federally funded. It doesn't make sense to maintain a Slimby slice. And I just don't think they had the time by the time they had to be able to process that.
I mean, it's nice to get rid of something.
It's actually from the system, but I think it's a little more complicated for us to actually now eliminate the
really?
slim that we have.
Oh, really? Okay.
But,
I was thinking it makes things easier, but maybe not,
it,
okay.
it does in the end, it's just from the programming point of view.
Right.
Makes it a little
Can you like put
complicated.
it on hold just in case?
So, I have another Medicare, the presentation that you gave to the House Healthcare Committee. I don't know that we have that up on our webpage, but it's different because it's earlier and it might have some information.
This page was, the other
Yeah.
pages should have all been the same, but this page.
Yeah, I
is
can see,
different
I see the evolution.
Yeah.
So we'll.
Yeah.
We'll put it up on our webpage. So what would be helpful, we got one more, have finished our questioning here, but to look at the rest of the bill, the implications review that you said. Dr. Dinosaur.
So we can, I'll just say, the DVA can't support the bill, but we can talk through the basis of the estimates for what the House passed in
Okay.
terms of the Dr. Dinosaur, or the coverage of pregnant women at a higher income level.
Yeah.
And the expansion of Dr. Dinosaur for 19-20-year-olds. We can talk through the cost estimates if you want to do that.
Yeah, we'll be good. I think Senator Hardy has a question first.
Well, I just want to point out, I mean, I know it's already been mentioned, but the amount of federal funding that we would draw down for this is significant and important that we don't lose that. I mean, the difference between these last two columns is federal versus state funding, and that's a lot of federal money that we would get to cover these people, so. Thank you.
So, yes, in terms of the whole bill, the department does not support
Yes, we can.
any part of the bill, any little piece of the bill.
Madam Chair,
We
I'm
try.
happy to speak a little bit
I
to
love
this.
the title.
For the record, Alex McCracken, Director of Communications and Legislative Affairs for the Department of Vermont Health Access. DVA really appreciates a lot of the work that's gone into this bill and wants to make that clear that we appreciate the work that's gone in from the House Healthcare folks, from the Healthcare Advocates Office and from other parties to shape this conversation. The department is not able to support the bill as written due to the cost of it and that being not included in the governor's budget. On the MSP expansion pieces, we're happy to be a resource on options as we've gone through today. And we certainly acknowledge the intent here and the need to address some of the things that have been outlined in the bill, specifically around the MSP gap. To the other parts of the bill, we cannot support program expansions due to their cost. And we would encourage perhaps that there might be other avenues to apply that funding if that was something the legislature was looking to do.
Okay,
What do you mean by that?
We would, I would request, sorry, I apologize, I'm a little turned around here. We can't support the program expansions in the bill. They do present a new cost that's not reflected in the governor's budget. We acknowledge that the study parts of that bill that are in the bill as written, that is something that we are able to do. We're not able to offer a position on it. So we really cannot offer a position on the bill this time.
okay, thank you. All right, but however, having all said that, it would be helpful for you to share with us your thinking about what the expansion of Dr. Dinosaur and the 19-20-year-olds and pregnant folks coverage. Just to hear that, and we'll hear from you. We might call on Mike Fisher next, but see how it goes, or I think maybe. More like,
And if I may, just
yes,
the fiscal note
yes,
is on the website. If you want to look, all the numbers are there.
Yeah.
And Steve was incredibly helpful in providing us the information we needed. So
do you want to go through the fiscal note rather than put, do you want to talk?
You know,
Is that work and then you're still in the room?
whatever you
Sure.
want.
Yeah, no, I think that's helpful. And Nolan has relied on you for this and that will bring through.
Send together a folder.
And I will say, let's go through the
Very good
the
presentation.
committee. We're gonna try to get to a break before we pick up our next topic. So we'll spend some, about the next 20 minutes or so, Nolan. And we'll take a short break and get back before 10:15, get started with the rest.
I need to zoom in. It's not, I didn't testify. So forgive me.
You're good.
You guys are so forgiving.
Did you just go ahead and answer? Yeah.
Uh,
Yeah. I figured, we're going to go over it.
all right.
Yes.
You guys are doing it.
That's the problem. That's the problem, is that once you lose us, if you can't ask a question, you lose us for the remainder. Correct. Because I don't know what I don't know. So,
Okay.
so I don't know. That's easy.
Did you write your question down?
So maybe you're the state marshal.
Then
Maybe.
you have to put your question down.
So she did some definition. Move acronyms and.
Oh, I got you.
Own the concept.
Okay, you do that. Okay, so I will repeat what I said. Since the party was out of the room, that we're gonna hear from Nolan on the fiscal note related to the bill itself, and those sections that we haven't looked at, the particulars. And then we're gonna try and finish that a little bit early and take a short break and come back to our budget discussion. If we can get there before 10:15, will be great.
Really weird. Apologies.
Is the note still April free? Or is it?
It is April 3. It's the most recent is as passed by the House of Representatives. So just share this.
Thanks, Dave.
Good for something.
You better get it. You guys are having too much fun.
We are.
It's Friday.
It is.
We have to laugh, otherwise we
It's a little function.
Rumor had it was Friday all day. I'm not sure I believe it. All right, for the record, Noel Langwell, the joint fiscal office, you have my fiscal note up above
Can you just make it, you can see that bigger?
for you.
That's good.
There's a lot in this fiscal note. This fiscal note is like a book. And it's intentional because in the back, all these concepts are complicated. Expansions are complicated, the Medicare savings programs are complicated. So what I, and then the revenues that are in this bill are complicated, and we're not gonna talk about the revenues. I'm only gonna talk about the policy stuff. And I think I actually went through this already a couple days ago, but I'll.
You did, but now
Okay, now it's fresher. So on the back page, there is some terms, Medicare Part A, Part B, Quimby, some BQI1, Part, just because the level set, so. I'm gonna start with page 5, which is the summary. And then I can work backwards.
Thank you for the appendix.
You're welcome. Yeah, so we're just gonna focus on the appropriations piece. We're not gonna focus on the revenue pieces. Because that's a different committee and I'm not the person that did those things. So the first piece is the Dr. Dinosaur expansion, and this builds in both the pregnancy, the expansion of pregnant individuals and the age 20 and 21. So I guess I'm gonna move back up. So this is the page 2. I have the breakout. And so the first year, 25 are, so as Stephanie mentioned, this stuff would not be able to start. The earliest they could start would be January of fiscal year 26. So what you're seeing in 25 are the implementation costs. There's a lot of work that goes into building a program, IT costs, et cetera, et cetera. So these are the costs that are associated with that. So for the young adult program, it's $600,000 gross. For the pregnant individuals, it's also $600,000 gross, for a total of $2 million to get the programs up and running. Much of that is matched. It's kind of a blended match. So I believe it was $360,000 in general fund to get it up and running. And then you have, starts in fiscal year 26, but that would be assuming a January start. That's about a half-year cost. So you're looking at, for the two of them, you're looking at roughly $8.2 million gross, about $3.5 million general fund. And then I have the annualized cost. So we don't know, this is, Medicaid costs grow over time, but this would be if those costs for 26 were annualized. I guess this is just estimates, but built into those annualized costs, I'm assuming that VFARM has been phased out. Whereas in the 26, with the half-year estimates, there's an assumption that there's sort of a transition period. So the VFARM costs are embedded in there, but in the annualized costs, we're assuming that the VFARM program is actually sunset, which is why the numbers aren't half of what they are in the other one. It's estimated that there's approximately 200 young adults who currently receive benefits through the premium assistance and cost sharing reduction programs that would also be covered in the program. And those folks are sort of embedded into the estimates as well.
Is that the number of estimated 18 and 19-year-olds? 200?
200 number of 18, 19-year-olds that are getting Vermont premium assistance
Correct.
and cost sharing reduction. So that's just this population. So you're looking at like who are already getting services through Medicaid, and then or some kind of expansion program or whatever, some kind of state subsidy, and then we move into this new program, and then those costs would be offset. Not a lot, small piece of stuff in your hands.
So for the 19 and 20-year-olds, we looked at, by age, our enrollment from year to year. We could see that 900 individuals that age from 18 to 19 no longer showed up in Medicaid. We can see that 200 of them show up in the exchange with premium assistance and cost sharing assistance. They're covered over the exchange. And so that remains 700 that are either getting coverage somewhere else, employer-sponsored insurance, or are going there, are not covered. But that's the basis of the cost estimate, those 900 folks that disappear from Medicaid in the whole Medicaid program. And so our cost estimate is that you would be keeping them on Medicaid, and you would be keeping them 18 to 19 and 19 to 20. So 1,800 more people would stay on the full Medicaid program than do now with this change in age. And that's what the cost estimate is based on. And we're netting off the value of the premium assistance and cost sharing in making our estimate. And we are making that estimate on these 1,800 young adults, kids, 19 and 20-year-old individuals, based on a blended rate of the child per member per month cost and the new adult per member per month cost because of their age. And that's the basis of the cost estimate. So 1,800 staying on Medicaid with this change, netting off the 200 that we helped through the exchange with VPA and cost sharing. And assuming that most of them, they would stay on Medicaid, they wouldn't have a reason to pick up employer-sponsored insurance or a reason to go bare, they would be covered by Medicaid.
Okay. Got it.
So a lot goes into this, a lot of thought and analysis.
And that's just on the implementation cost for both this and the pregnant women. That is again, programming and consulting cost in our systems. Because of the nature of these expansions, they create something called new category codes, and those are expensive to put into our systems.
So why would we be trying to remove folks off of employer insurance coverage, the Medicaid? Never seen the 18.
If they're on employer, if they are.
I'm sorry.
If you don't know where
We
they are.
don't know where they are. I mean.
We don't know where they are, but the way this is drafted, they would stay on Medicaid.
Well, for two reasons, or two big reasons is, well, first of all, yes, we don't know if they are, but two, even if they are, Medicaid is a much more comprehensive coverage than most employer sponsors. And it would save employers money because they would have to cover fewer people. So it's a cost savings to businesses and employers who might have to be covering people.
So the business doesn't pick it up, the state picks it up.
At a much lower cost per individual than a small business who is having to cover employees in there, or a school district or a large business. It's a much smaller cost per individual to have them covered on better.
Shifts from commercial businesses.
If there are any, right now,
Yeah,
there's
not
no, what I
necessarily.
heard Stephanie say is, we don't know where these people are going. It could be
Except for
one
the
person doing that.
200 we
It
see
could be
over.
nobody doing that, so it's just a guesstimate about
Right.
where folks are going. So it's difficult to speculate that anybody is paying more, lesser, and different, so,
I'm just,
yeah.
she can't count on herself.
Yeah, but that's, we don't know where they are, but they could be covered by employer sponsored insurance, or they could be uncovered. Nolan's the person to ask about the employer piece. I think the employer assessment would still apply to this.
It would,
Yeah, so.
but it's cheaper, but yeah, to the extent that people are the employees move off of commercial onto Medicaid, employers play an employer's assessment based on the number of uninsured, or number of people who they don't, uninsured, people that they don't cover insurance for folks that are on Medicaid. And to the extent that they move over there, they'd have to pick up, there would be some offset, it'd be cheaper for them to pay for their, the assessment than it is to pay for the premium, but they're still paying like probably $140 per quarter per employee, or per FTE, somewhere in that area. But they're paying something, but it's not as much.
So if any one of those would leave their ESI coverage, the employer would still have some obligation for them.
And some people in this age group are paying for high deductible plans through their college. And I happen to know a number of them who are doing that. And those are not necessarily covering much, and they're quite expensive.
Okay,
So the next part of this bill is technical analysis. And this would require AHS, DEVA, in collaboration with interested stakeholders to undertake technical analysis, doing several things. One would be expanding access to Medicaid and Dr. Dinosaur. We would look at rates paid healthcare providers delivering services to Medicaid and Dr. Dinosaur individuals. we would do another study of the structure of Vermont's health insurance markets. It was done many, many years ago. They would appropriate $450,000. 250 of that would be general fund, and the rest would be federal funds.
Okay.
And then the third big piece here is the Medicare Savings Program, Stephanie and Dan, right?
Danny?
Danny, thank you. Just went through, so I won't go through it again, other than the fact that House proposal is the $15 million proposal.
I do have a question though for Danny and Stephanie. If the level here is the $15 million level in 27, are the costs the same?
For implementation,
If it were a different level,
but that,
you'd still have $100,000.
yeah, the implementation costs, the programming costs aren't driven by the level.
The level,
of
I
income.
just want to make
It's
that
the work
clear.
that has to go into whatever change we make. It's not driven by scale of who's signing up or anything like that.
Okay. Alright. Okay, it's a lot to take in. Could you do me one more time for us, please? Talk about how you derive the number of 19 and 20-year-olds.
So we looked at by age, individuals that are enrolled in Medicaid when they're 18. And then are they enrolled at a later time when they're 19? And that's where we see in that 1 year of aging off, 900 that are not still in the program. Lots of 18-year-olds are still income eligible and fully in Medicaid. They age from 18 to 19, they are a child in Medicaid, and then they're 19 and they're an adult in Medicaid. But we have 900 that are not showing up in the program. They age off because the income is different. Your income is higher as a child, it's lower. It's a lower income, so you could, they're over 138% of poverty.
The eligibility.
Yeah. And we can see that 200 of them, 19-year-olds, are over in the exchange getting help. They may be buying a high deductible plan on the exchange, but they're getting premium assistance or CSR. We know that they're 19-year-olds are over in the exchange. So that's how we derived the estimate. We said, okay, there are 900 18 to 19-year-olds. You are moving to 20, so that's 2 years, same. So our cost estimate is based on 1,800, 900 times 2 for 2 years, times a blended Medicaid per member per month. And that blended Medicaid is a child per member per month, which is a pretty low cost, and a new adult per member per month, which is also a relatively low cost compared to our ABD populations. But that's the basis of the cost estimate is 1,800 new staying on Medicaid that aren't currently times our current blended cost estimate.
Thank you. Good. I think that clarified. Any questions now for Nolan? And we have Stephanie and Danny in the room. So if you have questions of clarification or understanding of the different categories. All right. Hearing any questions? All right, well, thank you. And did you want to make a comment? We want to stop at 2 minutes after 10. So I'm happy to have you make a comment.
Very quick comment.
Sure.
From here, Mike Fisher, healthcare advocate. I think, thank you everyone for your presentations that really helped. I think there's one or two details that I think would be good to get clarification on. One of them being that B-Farm premiums are split between the state and the federal is a dynamic that you didn't hear earlier that I think is important. We collect, Stephanie, correct me if I'm wrong, we collect, I think, $1.7 million in B-Farm premiums today. And due to the state federal match, we send about $1 million of it back.
It's just under 1.8 and it's about 750, yeah, so it's in about $1 million.
That does not seem.
So what does that mean? It's, neutral? No.
No, it's just that
my point is that collecting premiums from low income people to send back to the federal does not, to the federal government, doesn't seem like the right policy direction. I just wanted to make that point. And I think that's the one point I just wanted to make, but it's definitely.
Thank you, it's good,
Can I ask a question?
sure.
I'm processing what Stephanie said actually about the 18 and 19 or 19, 20, or sorry, Mike, to change.
Should we swap?
Yeah, this is the time.
Cause what Nolan's estimate says is that it would cover approximately 200 young adults. And what I think I just heard you say is that, and I've heard it in two different ways, so I'm misunderstanding what you're saying,
So
so.
it's 1,800 that would be staying on Medicaid.
For 2 years, over to 2 year period, over 900.
Yeah.
VPA, CSR.
So the 200 is what we are netting the savings of the VPA and the CSR on. So
Yeah.
they would stay on Medicaid, they would seamlessly stay on Medicaid with this proposal. They wouldn't go out, they wouldn't age off under, or income off eligibility when they turn 19. And that means they wouldn't go over to the exchange.
Okay.
And we wouldn't have it's a very modest amount of cost that is the VPA and the CSR that helps these 200 that do show up in the exchange.
Okay,
But it's 1,800 that would stay on that are not currently on. That is the basis of the programmatic cost estimate.
okay, so there are 1,800 that would benefit, okay, the way it's worded in here, it sounds like it's only 200 people.
No, I was trying to make the point that there were 200 people that
On the exchange,
on the exchange
Yeah.
CSR. And it'll be
Okay.
an offset of $225,000,
but in here, you don't mention how many,
because I didn't have that number until
Okay.
just now.
Got it.
No,
Okay.
that's why,
Thank you.
that's why
That
I
was-
asked for the clarification the second time.
right, and then I was just reading what Nolan wrote, and then I was getting confused, so that's helpful. It's actually 1,800, but there are 200 of those 1,800 are now getting subsidies on the exchange.
And we would estimate there are actually, I'm sorry, there's actually 400 because it's 2 years. of
2
age.
years, okay.
2 years, 2
Okay,
years.
okay, great, okay.
I think that's I'll double check that, but I think that's the case.
Oh, it's 1,400.
Okay, so then the cost savings would be higher than if it's 400.
No, I'm pretty sure that's based on support. Yeah.
Oh,
So I'll double check that, but
Okay,
that's
you guys could.
Yeah.
And let me know what.
I gotta go look at my source under.
Thank you, I
I
appreciate
haven't
it.
looked at it in 2 months, so.
All right, any other questions for clarification? Just the number of people is important to know who we're helping. at that level. Yeah, okay, anything else? Is there anything else that that Diva would like to share with us?
No, but if you didn't talk about it, but there's also the House passed a pregnancy expansion eligibility. and,
Yes.
If I think Nolan's note covers that pretty well.
Yeah.
So.
I know.
Just that we appreciate being in the room and happy to be a resource in this conversation as it moves forward.
Right, and we'll be happy when it's parts, of course, what we do this year.
It's embedded. It's embedded. Have it.
Do you have the pregnancy, where is that?
It's
Page
part of the,
2?
page 2, it's part of the section 3 expansion.
Yeah.
It's built into that chart, but we spoke mostly about the young adults.
Yeah.
But that was covering both.
Oh. And so I'm tempted, as I was earlier, to ask the question about how the determination about pregnant individuals was made, but it's just looking at history or,
It's one of the harder ones for the basis of data because it's an income cohort. We know how many births we have in the state roughly year to year. How many fall between that income cohort and how many would sort of uptake the Medicaid coverage. And we do think that a lot of them would uptake the Medicaid coverage and even maintain their other coverage, simply for the payment of out-of-pocket costs for the duration, because it's a limited duration of coverage for the year of pregnancy and a postpartum year at that higher income. And so it's an estimate based on that. Based on we have good cost basis information. It's pegging how many we will pick up there. And that's, we have our estimate of who falls in that income cohort. I had a conversation with Joyce Manchester at JFO.
okay.
It's fraught with always the challenge we have on income cohorts. Estimates in the state, because there's not great data, because we're so small, and the census information is not always reliable on the small samples. It's great data the tax department has on the over 65-year-olds. It doesn't work as well for everyone else below 65, because those are all sorts of different family dimensions and income categories.
Sure.
So, and this is not expanding services to pregnant women, it's just expanding the number of women who are covered.
And so it's coverage, so right now we cover pregnant women for their up to 212 or 17.
208, and then there's the 5% disregard, and this would go up to 3.
So at 138%, you're fully on Medicaid. If you are pregnant, you can be covered for your pregnancy and a year of postpartum coverage up to 212% of FPL, and this would expand up to
312. It would be, so the children and the pregnant women would have the same income.
It makes sense. When the kids are born, they would be eligible for Dr. Dinosaur, so why not have the pregnant mother postpartum covered by Dr. Dinosaur?
That's the motivation behind that section.
Great.
Okay, any other questions? Thank you. Thank you for your time. Thank you for restructuring that. I know I had talked to Senator Kitchell about getting more steps in there so we could understand what was there. Well, you've done that. Thank you. Thank you, Dan. And Nolan, we know we'll be back with Nolan and Al.
Thank you.
So we're gonna take a break. Ed will be back here. Please, that's 2